Hi everyone, welcome to Hub Bites. I'm Sunil Rege, consultant psychiatrist. If you're new to this channel, we cover all things psychiatry and mental health related. So if that's your thing, don't forget to subscribe. Today, I'm going to be talking about a really important disorder called chronic fatigue disorder. Some may also know it as myalgic encephalomyelitis. Now, one of the important things with chronic fatigue syndrome, and more recently, there is a big overlap between the symptoms of chronic fatigue syndrome and ME and long COVID. So quite a bit of what I talk about, not all, but quite a bit of what I talk about is will be applicable to long COVID as well. All right, so without further ado, let's jump into knowing more about chronic fatigue syndrome. So what is chronic fatigue syndrome? As I mentioned, it's also referred to as myalgic encephalomyelitis. It is a disorder characterized by extreme fatigue or tiredness that doesn't go away with rest and can't be explained by an underlying medical condition purely. That's not to say that there aren't a number of underlying medical conditions that need to be treated. They absolutely need to be treated. So in clinical practice, I do see a lot of chronic fatigue syndrome and myalgic encephalomyelitis. One thing I've learned is that every patient is different and every patient has a range of different risk factors. Their symptoms are very different. For example, some may have POTS, some may have prominent brain fog, some may have a combination of both. Some may have infections, some may have organic conditions or medical conditions, such as thyroid autoimmunity or other autoimmune disorders. This is one of the most complex disorders, I would say, in medicine that results in a huge burden overall. And to be quite honest, we still don't know enough about it. The other thing is many patients can be dismissed as well. Say with diagnoses such as just functional neurological disorder or conversion disorder. And many patients often feel dismissed that, being told that it's just in their head. So it's really important that we do take it seriously. We recognize the limits of medicine and psychiatry as a whole and listen carefully. We know that there are a number of aspects that can help patients in this particular condition. So again, there is a lot to know about chronic fatigue syndrome. I've written a detailed article on psychscenehub.com where I go into much more detail. But here I'm going to give you a snapshot of what is CFS or ME. Now, what is the cause of CFS? Causality in medicine is a very complex issue. So there's never one single thing that leads to CFS. There's a combination of things, but what we find when we take a history of individuals with chronic fatigue syndrome, we ask them about their past, we often see certain exposures that might be present, and that's where we look at certain associations or links. Now, one of the things that we find very prominently is viral infections. So Epstein-Barr virus, glandular fever, often tends to be quite a prominent part in individuals' histories. So exposure to glandular fever and then onset of chronic fatigue syndrome subsequently. And this is where COVID comes in as well. The coronavirus exposure and long COVID, a very similar pathogenesis may be involved. And we know that long COVID is a documented entity and many patients now presenting with it. We then have genetics. Some individuals just seem more prone to the development of chronic fatigue syndrome. Sometimes there's a family history as well of chronic fatigue syndrome or other pain syndromes that's present. Stress and trauma is also a risk factor. In fact, childhood trauma tends to be, individuals with childhood trauma tend to have higher rates of chronic fatigue syndrome as well. Now, weakened immune system. I've talked about weakened immune system because part of it is related to certain immune factors tend to be lower in individuals with chronic fatigue syndrome. But on the other hand, there also seems to be neuroinflammation, which means there's excessive release of cytokines, excitotoxicity, cytokines that aren't needed that affect the brain. And we know that certain parts of the brain where the fatigue areas are, for example, where the frontal lobe, the cognition is affected, dopamine goes down. So it's a really complex pathogenesis. All of this pathogenesis has been covered in a lot more detail. Then we have hormonal imbalances. So hormonal imbalances, as I mentioned, the HPA axis dysfunction, which is a hypothalamic pituitary adrenal axis dysfunction, seems to be linked to this. And there's links between HPA axis, trauma, and then chronic fatigue syndrome, because we know trauma disrupts HPA axis. It's something I've covered in the other video on neurobiology of PTSD, or neurobiology of stress as well. So these are some of the factors that are associated with chronic fatigue syndrome. So how is chronic fatigue syndrome diagnosed? Now, I'll go through the specific Canadian consensus criteria, but generally, let's look at some of the domains. So firstly, we've got a reduced ability to do usual activities for 6 months or more because of fatigue. So fatigue is one really important, chronic fatigue syndrome. And so fatigue is an important part. And one of the things with this fatigue, it's quite peculiar because you see in depression, individuals can be lethargic and feel tired. But in depression, individuals tend to improve with activity. And that's why behavioral activation tends to be a strategy. Chronic fatigue syndrome, individuals tend to worsen with activity and exertion many occasions. So that's one. Second, we have worsening of symptoms after usual physical and mental activity, as I mentioned. It could be difficulty thinking, problem sleeping, sore throat, headaches, feeling dizzy, or severe tiredness. Then we have trouble falling asleep. Circadian rhythm dysfunction tends to be a very prominent part of chronic fatigue syndrome. Then there should be other things such as problems with thinking and memory. Individuals talk about a brain fog. This is the cognitive components. Then worsening of symptoms while standing or sitting upright. This is the autonomic nervous system dysfunction that occurs. Diagnoses of POTS, for example. So in order to receive a chronic fatigue syndrome diagnosis, your doctor will rule out other potential causes and review your medical history. This is so important to really go through a detailed medical history. And then we talk about the main symptoms, the duration, the severity, and then using the Canadian consensus criteria is one of the criteria that can be used to confirm the diagnosis. So what are they? And this CFS criteria is quite useful. As you can see, the illness length here, adults 6 months, children 3 months. Fatigue, as I mentioned, prominent. Next, post-exertional fatigue and malaise. Then sleep dysfunction. This is a characteristic. Individuals describe what's known as a wired fatigue. They're very tired. They want to fall asleep, but they're wired. Individuals talk often about racing thoughts. They just can't sleep. This is hyperarousal that is very different from individuals not being able to sleep due to other causes of insomnia. And we'll talk about some of the potential medications that could address this, because this sort of hyperarousal also occurs in post-traumatic stress type symptoms. Then we have pain. Now, fibromyalgia can be comorbid with CFS, right? So fibromyalgic symptoms, which is fibromyalgia is characterized by, I'll do a separate video another time, but it's characterized by what's known as allodynia, which is a heightened sensitivity to pain. So many individuals with fibromyalgia will often complain of pain all over the body and can be very tender to touch, right? And there's more evidence recently that, particularly from long COVID, where individuals have had this fibromyalgic sort of type of pain, chronic fatigue syndrome, where they're talking about endothelium in the vessels being affected and microclotting. So there's more to know, and in chronic fatigue syndrome and COVID as well. I've done the video on COVID neuropsychiatry as well. And one of the pathogenesis with COVID is this increased sticky blood type aspect, very similar to what happens in antiphospholipid syndrome, increased antiphospholipid antibodies. I know I digress, but it's a really fascinating sort of pathogenesis, and there's overlap here as well. So fibromyalgia tends to be really important, often diagnosed by a rheumatologist as well, by testing the pressure points. Then we have cognitive dysfunction. So this is another really important part of the chronic fatigue syndrome. And in cognitive dysfunction, individuals describe what's known as a brain fog. And this affects memory, multitasking, affects executive function, attention, concentration, can be very disabling. And then one symptom from 2 of the following categories. And you can see here, autonomic nervous dysfunction. We know that POTS is closely linked with chronic fatigue syndrome. Sometimes the diagnosis just gets put down as POTS and one just focuses on the POTS, but it's important to look at whether POTS occurs with fibromyalgia, whether it occurs with brain fog, etc. Then we have neuroendocrine dysfunction. This is where it becomes the HPA axis dysfunction, cortisol, adrenal function, thyroid autoimmunity, ruling out Addison's disease, which is, antibodies against the adrenals. So many things need to be ruled out adequately. And then immune dysfunction. So individuals can be very prone to infections as well in this condition. Now, one other thing I would also bring in here, individuals tend to have quite a prominent mood component here. So you can put it either in fatigue or sleep dysfunction or cognitive, but mood. And often the mood tends to have a fluctuating sort of pattern. Depression can present, anxiety can present, but also mood instability can present. So how is it treated? Now, again, as in every treatment, I say this is something that is general only. It is not medical advice because every patient's different. It's so crucial that you discuss this with your doctors. But what are some of the things that are evidence-based? So firstly, when we look at it, we have lifestyle changes. So diets, mitoprotective diets. So there's some evidence that, intermittent fasting, increasing ketone levels, neuroplasticity, some of those things can be beneficial. Lifestyle modification. So again, removing certain toxic elements such as alcohol, say cannabis use, other substances, etc. Then pacing, really important to pace oneself and not push. So in my experience, I've had patients where even sometimes during the initial phases of treatment, they tend to improve. And then because they improve, they can feel well and do a little bit too much and go a few steps back. So I often mention that it's crucial to pace yourself. The other thing I often find is in terms of personality factors, individuals can often have higher levels of perfectionism. They're driven individuals, higher levels of perfectionism. You're previously high functioning, sometimes driven. And that can sometimes be a double-edged sword because when they're getting better, they can really push themselves. That's a personality sort of factor that I've identified in some cases. And then energy conservation exercise. Then we have nutritional supplements. And here, evidence-based vitamin D, I would say vitamin D is so important in treating chronic fatigue syndrome. Often would look at keeping levels at the higher end of the lab values, and sometimes, significantly over it. Greater than 70 at least, I would say. And then probiotics as evidence-based. And this is where the gut-brain axis comes in. Because gut-brain axis is linked to neuroinflammation as well. I'm sure I'll do another video on the gut-brain axis. But I've done a short animated sort of video on that, so you can check that out. But probiotics show some evidence. Magnesium, again, really important. Anywhere between 200 to 400 milligrams can be utilized and over the counter. Vitamin B12, B complex, so folate's important, vitamin B12 is important. Essential fatty acids, so this is where you have the omega-3 fatty acids, and we know that, EPA, eicosapentaenoic acid versus the DHA, often the ones with higher levels of EPA tend to be more evidence-based in psychiatric disorders. Then we have coenzyme Q. Coenzyme Q, and then, this is basically what niacin gets converted to. So the nicotinamide adenosine dinucleotide, NADH, is evidence-based. Acetyl L-carnitine and antioxidants. Now, of course, all of these on their own are unlikely in the severe cases to change things. And this is where we're looking at a cumulative effect, right? Then we have psychotherapies. In psychotherapy, CBT and graded exposure therapy. One of the things I find here is that, sure, patients get referred to graded exposure therapy or CBT, but when a person sometimes is extremely fatigued, just this doesn't cut it. Individual might be experiencing autonomic dysfunction, significant brain fog. They might not actually be able to engage in CBT. And this is where we've got to deconstruct the syndrome and address each component of the syndrome, which I'll touch on in a bit. Then we have pharmacological treatments. Now, pharmacological treatments, antidepressants, and I'll talk about, how we sort of target things. Now, remember, we have fatigue. We have post-exertional fatigue or malaise. We have mood components, either depression or anxiety or instability. We have sleep circadian rhythm dysfunction, right? And we have cognitive aspects. We have pain, right? So I've got to look at all of these things when treating. And now one of the things I find is addressing the hyperarousal symptoms first, right? Which can help with the sleep and bring down the overall level of tension that individuals generally have. Some of the medications that can be useful here are clonidine or prazosin, the alpha-1, alpha-2 antagonists that I've covered previously. Again, another video. These can be extremely useful in promoting sleep and reducing their hyperarousal. We know that they are agents that actually promote deep sleep, NREM sleep, right? Which is important for memory consolidation to reduce the fatigue during the day. Now, of course, it's crucial to rule out medical conditions, obstructive sleep apnea, for example, thyroid dysfunction, restless leg syndrome. All of these need to be treated as well because chronic fatigue syndrome can be comorbid. So when we think about this wired fatigue, we can address that. But let's say a person with chronic fatigue syndrome has POTS. You see, then prescribing agents like clonidine or prazosin will drop blood pressure. So that's something I won't do at that stage. It can be introduced later on. This is based on my clinical experience of having treated patients. So what tends to happen, it occurs as a balance. And one of the things that I tend to do in severe cases of chronic fatigue or fibromyalgia is I consider an admission because the environmental stresses need to be taken out. I find it extremely difficult to carry out outpatient treatment because there's so many stresses that are there. And also individuals can be very, very sensitive to changes in medication. So they have heightened side effects. And that might be a combination of a few things. Allodynia, the heightened sensitivity, the fibromyalgic component. So often they're so attuned to their body that small changes can, particularly with changes, medication changes, can be misinterpreted sometimes as side effects. So there's a lot of reassurance, therapeutic alliance, understanding, and trust that needs to be built through this treatment. This is one of the most important things I've found. And time is a big factor. We're looking at a 6 month to 1 year process. The admission, of course, might be shorter, but we're looking at it as a process because each person's different. I need to see how each medication change results and how patients react. So when we're thinking about antidepressants, for example, if the individual's got fibromyalgia, I can consider antidepressants that are evidence-based for pain. So duloxetine, for example, or milnacipran. Now, these are very, very helpful in pain. But duloxetine also assists with the cognition component, right? Then, some other agents such as we're looking at here, antivirals. Now, of course, antivirals, monoclonal antibodies, this is where liaison with the rheumatologist can help, right? Steroids, same. Liaison with the rheumatologist can help. There's some evidence for staphylococcal toxoid vaccine as well. Anti-inflammatories can be prescribed, particularly, again, for pain, etc. There's some evidence for low-dose naltrexone, really low-dose naltrexone. Analgesics can be prescribed, again, for pain. But from a psychiatric component, I'll talk about some of the things, the strategy that tends to work. So treating the wired fatigue, treating the pain, and sometimes using combinations. So sometimes agents such as stimulants are also evidence-based. And what's really, really interesting is stimulants such as dexamphetamine or methylphenidate are also evidence-based in POTS with brain fog. In fact, 2019 article talked about brain fog and POTS, and there's very good evidence for agents such as modafinil or modafinil. These are agents that stimulate the orexin neurons, which promote wakefulness, right? In the neurobiology of sleep, I've covered orexins and, these wakefulness components. So modafinil or modafinil can be very useful, or stimulants such as methylphenidates and dexamphetamine. And they actually do not cause, so trials have shown no significant effects, problems with the POTS. So I've used them successfully in many cases. And what happens is as the blood pressure starts going up, that's when the wired fatigue can be treated by using clonidine, and you get an optimal balance. But this is something that needs to be done in a specialist care, and of course, in a supervised environment as well. Now, for mood components, mood stabilizers, anticonvulsants, and lamotrigine can play a very big part. And in the initial stages, a multi-pronged effect is needed. in order to provide good benefits. And medication, then the graded exposure therapy and CBT tends to work really well. But if fatigue, brain fog is so significant, then there's a big barrier. And that's where medication needs to come in. So this is not about saying one thing will work. And this is one of the things I've learned in chronic fatigue. It requires a multi-pronged approach and a multidisciplinary team as well. Physicians, rheumatologists, general practitioner, nurses, nurse colleagues, occupational therapists, physiotherapists, multi-pronged approach in order to address this particular condition. And there is, of course, some evidence for complementary therapies, acupuncture, rehabilitation, abdominal tuina, and fecal microbiota transplant. But all of these things are, of course, experimental. As you can see, this is from the reviews, the references down here that I've covered this. But I hope that this has given you an understanding of how complex this particular condition is. And, everything that I've covered today, I've covered it as a general sort of overview, right? Every person's different, so each aspect needs to be targeted appropriately in discussion with the doctor. But I hope that this will help you and anyone else, that might be experiencing this condition. A lot of this is also relevant to long COVID as well. So if you've liked this video, please leave us a like, hit the like button. Of course, don't forget to subscribe. And I look forward to seeing you in another edition of Hub Bites. Until then, take care, stay safe. I'll see you next time. Bye-bye.